notre session spéciale sur les lignes directrices canadiennes sur la PrEP et la PPE contre le VIH. Thank you so much all for coming to our special session today about Canadian guidelines on HIV PrEP and non-occupational PEP. We're going to dive right into the program because we only have 60 minutes, but we're thrilled that you're all here. We're going to start with the conflict of interest slide that's listed here. I want to just draw your attention to the very last sentence at the bottom of the slide here and mention that aside from the use of tenofovir disoproxil fumarate plus emtricitabine for daily continuous PrEP, everything else that we're going to mention with respect to the use of antiretrovirals today is for an off-label indication in Canada. The format for today's session is listed here, so I'm going to start with just a few moments about the methodology that we used and an introduction to the process that we used, and then my colleagues that are seated to my right are each going to take a turn talking about some of the highlights of the recommendations that we've come up with respect to the eligibility and provision of PrEP and non-occupational PEP or nPEP respectively. And then at the end of the session, or towards the latter half of the session, we really are excited about hearing your feedback, which will be an ongoing process. You can provide that feedback in one of three ways. There are there microphones? You can scream really loudly about at us and let us know what you're thinking. You can also fill out one of the comment cards. There's about 4 comment cards on each table, and then once you fill that out, you could hand it to any one of the volunteers from the CTN that are here. They're waving their hands here. Kevin and Sean and Jess will happily take your cards. You could also drop them off later on during the CAHR conference at the CTN table, or you could email your comments to Kevin Pendergraft, whose email address is at the bottom of the printed copies of the recommendations in front of you, and we'll also show that at the end of the slide deck today. So let me just briefly introduce myself. My name is Darrell. I'm an infectious diseases doc at St. Michael's Hospital and at the University of Toronto. And in terms of the rationale for why we've spent all this effort putting together guidelines, I think this audience knows very, very well that according to data from PHAC as shown here and as reproduced in a table format in the printed version in front of you, despite all of our best efforts, we continue to see new diagnoses of HIV across the country year after year after year, despite all of our best efforts. And that tends to be concentrated in certain higher risk populations or priority populations. So in particular, men who have sex with men and other gay and bi men across the country have a rate of HIV incident infection that's 71 times the national average. That for people who inject drugs is 46 times higher than in the general population. And we also see elevated incidence in other populations as well, certain Aboriginal populations in certain parts of the country, people from HIV endemic countries, etc. And a lot of the criteria that are situations in which one would want there to be clinical guidelines for a condition really do apply to PrEP and nPEP as well. We certainly hope that these guidelines will ultimately improve the quality of care for individuals. We want to summarize research findings that individual clinicians may find very difficult to synthesize on their own. We'd like to reduce inappropriate variation in practice and promote the efficient use of resources and inform public policy in doing so. And then also identify gaps for future research. The intended audiences for this work include primarily clinicians, but clinicians from a variety of backgrounds, as you can see listed on the slide. We also hope that these guidelines will be useful for policymakers and community organizations alike. So let me briefly outline the approach that we took to developing these guidelines today. Importantly, we really wanted this to be a strictly evidence-based process. So to achieve that goal, we've used a rigorous and widely accepted methodology to develop them that's called the GRADE process. We strove to have a national and multi-sectoral representation on our panel of guideline developers, and that includes specific members that have participated in the development of provincial guidelines on PEP and or PrEP where they exist in certain jurisdictions in Canada. The funding for the development process came entirely from CAHR funding, and we're grateful to the CAHR for that, as well as in-kind support from the Canadian HIV Trials Network, or the CTN. And in terms of relationships with industry, we have requested industry funding for our work, but only for dissemination activities once the guideline is completed. So the actual development of the guideline is entirely funded through public funding. We've also asked that all panelists declare their actual or perceived conflicts of interest at the start of the process, and they will also be asked to redeclare those at the end of the process when we publish, because such relationships can change over time. And I really want to recognize that 25 or so individuals from across the country that have poured a lot of effort into this process over the last better part of a year, as listed here. So this is a bit more detail about our methodology. So going back to the end of the summer of 2015, we formulated our guideline questions, including articulation of the key outcomes that we were interested in. And then we engaged an information specialist, or a librarian, to help us conduct 11 separate structured literature searches to address our various questions. Each one of those 11 searches was conducted concurrently in Medline, Embase, and CINAHL up till January 8th of this year. And then this yielded over 7,000 separate abstracts, each of which was reviewed by 2 members of the panel to select which articles we wanted to retrieve in full. We then extracted evidence from those selected articles, including an assessment of the quality of that evidence using a scale from A to D that I'll show you in just a moment. And then we have spent a lot of the last several weeks and months formulating actual recommendations that you see in draft format today. Finally, we're at the stage now, as of this moment, of stakeholder consultation. So we're very, very interested in all of your feedback. And we will also seek feedback from some of the organizations you see listed on this slide. There's a number of organizations that have pre-committed to endorsing the guideline, as you see here. I'm not going to read them all out. And then on the right, you also see a number of organizations whose processes for endorsing guidelines involve submission of the finalized or the pre-final text. So we'll be approaching those organizations with the document once it's ready in the coming weeks. So each of the recommendations that you're going to see is graded in terms of its strength as well as its quality, and those 2 things are different from each other. So the strength of a recommendation reflects the extent to which the panel was confident that the desirable effects of an intervention outweigh the undesirable effects, and that can happen, that can lead to a categorization as either a level 1 strength recommendation, something that we firmly recommend, or a level 2 recommendation, which is something that's a little bit softer than that, something that we think clinicians should consider. The quality of the evidence is then graded from A to D, and you can see here on this table that high-level evidence, according to the grade framework, is rated A, and that would be a starting point, for example, for well-conducted clinical trials that are randomized controlled trials. That can go down to moderate for B, low for C, or very low for D. C corresponding to a starting point for observational level data, and we can adjust the rating of the quality depending on a critical review of the methodology that was used for the study. So I'm going to, with that background, I'm going to start diving right into the recommendations themselves. You'll see that the section, that the guidelines start with 6 general recommendations, and I'm going to use these also to illustrate the concept of the grading system that I just mentioned. So recommendation number 1 is that PrEP and nPEP should be part of a combination prevention strategy that includes behavioral interventions such as condoms and risk reduction counseling. We graded that a grade 1A recommendation. 1, because it's something that we definitely recommend. A, because we feel that this is based on well-conducted randomized controlled trials looking at combination strategies that did or did not include these interventions. Recommendation number 2 is that health systems should strive to engage a broad number and range of qualified clinical providers in prescribing and providing follow-up for PrEP and nPEP. And that could include specialist and family physicians, nurses, nurse practitioners, and pharmacists where provincial scope of practice allows or under appropriate delegation of responsibility. We graded that as a 1D recommendation. 1, because again, it's something that we do actively recommend, but D, because this is based on a very low quality of evidence. So that gives you a sense of our first 2 recommendations, as well as how the grading system works. My colleagues, as they present the actual recommendations in the next few minutes, are not going to elaborate on why we chose the grading system, but I just wanted to use these as illustrative examples. So with that, I'm going to move on to my next presenter. Unfortunately, Dr. Réjean could not be here in Montreal, so subbing in for him is another member of that working group, Jody Jollimore, who is one of our community members on the panel development.
Thanks, Darrell. So our working group was responsible for PrEP eligibility. And I'm clearly not Réjean, but I am Jody Jollimore, so I'm going to be presenting recommendations 7 through 10. So the first is number 7, and that is that HIV-negative MSM and transgender women reporting condomless anal sex within the last 6 months should be counseled and evaluated for the appropriateness of PrEP. We graded that 1D. PrEP is not recommended in the context of a stable, closed relationship with a single partner with no or negligible risk of having transmissible HIV. We graded that 1C. PrEP is strongly recommended for MSM, grade 1A, and transgender women, grade 1B, reporting condomless sex within the last 6 months and having reported any of the following. The first being a bacterial STI diagnosis, reported in the last 12 months, a HIRI MSM risk score of 11 or more, ongoing sexual relationship with an HIV-positive partner with a significant risk of transmissible HIV, And D, prior PrEP use. 8 and 9 are for the heterosexual population. Number 8 is we recommend PrEP for heterosexual serodiscordant couples reporting condomless vaginal or anal sex where the HIV positive partner has a significant risk of having transmissible HIV. We graded that 1A. Number 9, PrEP may be considered for heterosexual serodiscordant couples reporting condomless vaginal or anal sex where the HIV positive partner has a non-negligible risk of having transmissible HIV. We graded that 1B. This includes HIV negative women attempting to conceive with an HIV positive partner who has a non-negligible risk of having transmissible HIV infection. We graded that 2D. And the final recommendation around eligibility is number 10, and that's for injection drug users. PrEP may be considered for people who inject drugs in whom other harm reduction interventions, example, needle exchange, opiate substitution therapy, have already been implemented. And we graded that 2B. We're also including in our section 2 receiver operator curves, tools created by the CDC for capturing people at high risk of infection. Thanks, Darrell.
Hi, I will be presenting the recommendations 11 to 26, which relates to the provision of PrEP. So recommendation number 12, daily tenofovir emtricitabine is recommended for PrEP, and it's a grade 1A. 13, as an alternative in MSM, because it has only been studied in MSM, tenofovir emtricitabine administered on demand, 2 pills at 2 to 24 hours before first sexual exposure, followed by 1 pill daily until 48 hours after last sexual activity, may be considered. 2A. The evidence that support these recommendations are the randomized controlled trial, IPREX, the trial, observational trial, PROUD, and the randomized controlled trial, agrégée. So the grade of the evidence is based on the large size of the population studied on the continuous arm, continuous administration. And the second recommendation is based on the agrégée trial. There also has been evidence of the success of this regimen in several other PrEP trials in heterosexual couples that are listed there, and you can have a complete bibliography that support these recommendations. So the other recommendations relate to the evaluation and the monitoring on PrEP. So recommendation 16, baseline HIV status should be determined using a lab-based 4th generation assay when available or alternative for all people in whom PrEP is being considered. This is a grade 1C. Of course, this is very important to eliminate, not to offer PrEP to somebody who would be HIV positive because of the risk of developing drug resistance and wasting a potential treatment option. Recommendation 18, there's no 17, sorry. Serum creatinine is recommended for use of tenofovir-based PrEP, grade 1C. Routine DEXA to assess bone mineral density is not recommended unless otherwise indicated according to the osteoporosis Canadian guidelines at baseline or during PrEP use. Tenofovir emtricitabine PrEP may be considered in persons with low bone mass or osteoporosis after discussion of the risks and benefits, grade 2D. Recommendation, the numbers are a little bit off, but we'll find our way through it. We recommend follow-up clinical and laboratory evaluation for HIV infection, medication toxicity after 30 days and every 3 months thereafter, and incident STI and hepatitis infections every 3 and 12 months respectively thereafter, as indicated by ongoing risk exposures for patients on PrEP. So hepatitis C every year and the others every 3 months. PrEP clinical encounters should include patient counseling on risk reduction strategies, medication adherence, potential drug toxicities, and strategies to minimize those risks. So the rationale for routine screening every 3 months for STI is the high frequency of bacterial STI, and this is a study that was presented at CROI recently, which showed that if they had only screened for STI every 6 months, they would have missed 77% of STIs occurring. So the CDC guidelines recommend every 6 months, so they had done this nice study which showed that there was a benefit of screening for STIs more frequently. And that summarizes our recommendations.
Just as Mark's coming up here, I'll just clarify one quick thing. Yeah, indeed, in the slides that we're presenting, we're not showing you every single one of the 59 or so recommendations in our package in the interest of time. So we've just selected a few that we thought would be particularly interesting. That's why not every single number appears. That's why they're also not entirely in sequence. So just for clarification.
Thank you very much. We're going to switch gears now and talk about non-occupational post-exposure prophylaxis. And I'll go through the eligibility criteria, and then we'll hear about the specific regimens again. So if we go through our recommendations, the first recommendation we have in this area is to make sure that healthcare providers assessing somebody for nPEP are able to distinguish between consensual and non-consensual exposures. In other words, recognizing when somebody has not consented to this exposure through influence of drugs or sexual assault, and be able to refer for sexual assault services and counseling where appropriate. This becomes important when we look at some of the adherence supports later on. We recommend that in individuals who are taking PrEP, which we've just heard about, that if they're using it as prescribed, in other words, continuously or on demand in an appropriate fashion, they themselves do not require nPEP after a potential HIV exposure. Obviously, that's the role of PrEP, is protect them in that situation, and that's a grade 1B recommendation. Finally, however, if you're not using your PrEP as prescribed, initiation of nPEP may be considered when we go through the recommendations looking at eligibility criteria. And the reason for considering nPEP in the setting of PrEP is from the open label IPREX-OLE extension. You can see adherence really is a key for full protection. And if you're taking your pills sporadically, less than 2 or 4 times a week, you would have still an increased risk for HIV incidence, really necessitating the need for consideration of additional protective strategies in somebody who has been non-adherent. So, who should be considered eligible for nPEP? Well, we recommend nPEP in individuals who present within 72 hours of having an exposure that is moderate or high risk for HIV transmission with or from an individual who themselves has a significant risk of having transmissible HIV. This is language that you would have heard from Jody earlier. We'll go through a table in a second to try and clarify our thinking behind this assessment process. nPEP can be considered, so see the difference in the wording between recommend versus consider here for individuals who present within 72 hours with, again, a high to moderate risk exposure, but from an individual who has a low but non-negligible risk for transmissible HIV. So we distinguish between those two source situations. So here is our color-coded table. I'm a big fan of color coding. I always find it's the easiest way to consider things. And this was developed by Patrick O'Byrne from Ottawa, who unfortunately can't be here today. And this would lead people through the key assessments for HIV transmission. So the risk of HIV transmission is essentially the equation of the risk that the source has a transmissible HIV times by the risk of the exposure type. And you can see here in table 6A how we have graded or evaluated based on cohort studies and other available biologic evidence for the risk exposure type. So they're high risk, moderate risk, or low risk exposures. For high risk exposures, unprotected anal receptive intercourse obviously is the highest risk exposure that we might see, followed by needle sharing, and other higher risk exposure would include receptive vaginal intercourse, and anal intercourse where you're the insertive or penetrative partner and are uncircumcised, based on a number of studies, particularly in Australia, that do differentiate the effects of circumcision in this situation. Moderate risk exposures, again, would be here in yellow, which would be anal and vaginal penetrative intercourse if you're circumcised. And then low risk exposures, where the risk of HIV transmission from that exposure type would be extremely rare, would be oral sex. So we have to take this table and we multiply it with our next table, which is the likelihood that somebody has transmissible HIV. And this, of course, is influenced by our key or priority populations, starting with somebody who is HIV positive, situations where HIV status is unknown, but they belong to a risk group that has high prevalence HIV, so MSM, injection drug users, or PWID, or sex trade workers. We differentiate then between low but non-negligible risk and negligible risk based on data. So if we look at negligible risk, this is situations where people are known to be HIV negative, or situations where people are HIV positive but are very well controlled on their antiretroviral regimen. So they have confirmed undetectable viral loads for at least 6 months with no other concurrent STIs that might influence transmission at the type of exposure. So a very key understanding of transmission source is important when we complete this evaluation. So finally, you multiply these two together and we get our final assessment of likelihood of a risk of transmission. And you can see again here situations where we indicate the action that should be taken based on those exposures. So if you've had a significant exposure type from somebody who has a likelihood that they have a significant likelihood of having HIV, then we obviously would recommend nPEP. And you can follow the table through to situations where nPEP would not be recommended or required, regardless of your likelihood of HIV exposure, if you've had a low-risk exposure type. I think that is the last slide in that section. So we'll hopefully be able to go through that in the question period if people have more questions.
Great. So I'm just going to go through, once we've decided that PEP is indicated, how do we go about rolling this out? So the provision of PEP. So once PEP is indicated, we are recommending that 3 agents be used, and so there is no longer a risk stratification, a high or low, 2 or 3, it's always just 3. And the regimens would be either an integrase-based regimen or a protease-based regimen. The integrase-based regimen would be a tenofovir, TDF at this time, FTC daily plus a raltegravir BID dosing. Or for protease-based regimen, it would be TDF FTC plus a once-daily darunavir-ritonavir combination. And certainly, there are certain advantages with either regimen. So raltegravir being that it is it's not involved in as many interactions as a protease-based regimen, but the disadvantages, of course, would be that it's twice daily dosing, and there's a lower genetic barrier to drug resistance. Whereas, of course, in the PI-based regimen, we have a once daily dosing and has that higher genetic barrier to resistance if there's resistance that's suspected. Unfortunately, which is, I think, one of the main disadvantages, of course, maybe some of the side effects, and of course, the drug interaction potential of CYP3A4 substrates and inhibitors. And of course, this is based on studies that have been published, several large cohort studies from Boston and Australia's group, and then, of course, a randomized controlled study, the RAL-PEP study presented at CROI, that randomized raltegravir versus lopinavir-ritonavir. And then, of course, the protease-based regimen, the thinking there, of course, was the randomized controlled study that was presented at CROI as well by the German group, that also showed that a boosted darunavir was non-inferior to, at the time, their standard, which was TDF-FTC plus lopinavir-ritonavir. And so once treatment, I guess just before treatment is started, we're recommending that baseline HIV status be determined using a 4th-generation assay when available for all people, and when available, a point-of-care testing should be used for initial screening. However, neither of these tests, PEP should not be withheld during pending the results of these investigations. While treatment is started, we believe that ongoing laboratory monitoring is only recommended for those with baseline abnormalities or those who develop signs and symptoms of organ dysfunction or medication-related adverse effect that might urge you to do some testing. And then I guess at the end, HIV serology with a 4th-generation assay is recommended at 12 weeks following the exposure, so 8 weeks after the conclusion of PEP. And that is based on the rationale. That rationale is based on a study that was published talking about the probability of false negative and that the window is at about 18 days. So that we should be sufficient at 12 weeks. And of course, if you extend it longer, then of course there would be a higher loss to follow up if you did a prolonged follow-up.
All right. So there is a 5th brief section to our guideline as well. Another working group that was led by Julie Kill from Vancouver looked at what other things should be looked at in someone who comes in for a biomedical intervention. We think of PrEP and nPEP as strictly biomedical interventions, but the panel recognized that these are actually opportunities to engage a person in a diverse range of different sorts of interventions that could include attention to syndemic conditions, attention to mental health, for example, substance use, etc. So we have some brief recommendations in that regard as well for any patient in whom PrEP or nPEP are being started or considered. So with that, we're about halfway through the hour, and I realize that it's been a bit of a whirlwind perhaps. We've thrown just a bunch of the key highlighted recommendations at you and showed you some of the evidence behind that. But really what we're most excited about for this session is really the opportunity to engage in a bit of a dialogue with the broader HIV community in Canada. So we're going to do that in 3 ways. The most important one is that folks in the room voice their opinions and start to ask questions by coming up to, by waving their hand madly, and then one of the CAHR volunteers will come to you with a microphone. In addition, as we mentioned at the beginning, if you have thoughts about this that you're thinking about right now, or that you think about even in the next few days or weeks, that you can fill out a comment card, and you can, again, either leave that with one of the volunteers from the CTN, Jess or Kevin or Sean, or you could also go to the CTN's exhibitor booth and drop it off. And then also, we invite you to continue to reflect on this and digest what's in front of you today and then letting us know your feedback by email. So Kevin Pendergraft from Communications at the CTN will be available at this email address, not only for you to provide comments, but also if you're interested in having an electronic copy of the guidelines. We realize that not everyone in the room has a copy. We realize that, I'm just realizing now that some of the color coding meant that it was hard to read sections of the document. So you're welcome to contact Kevin and provide feedback all the way through at least the month of May. So with that, thanks very much to all of my co-presenters for giving you some of the highlights or telling you about some of the highlights of the recommendations. And we really hope that folks in the room will approach us with some of their feedback. So can we open it up to the room for further discussion? If you have a question, raise your hand, as I see is being done in that part of the room right there, and someone will come to you with a microphone.
Thank you. Thank you. Does it? Yes, it does. Okay. So given that the partner study used a detection limit of 200 copies per milliliter, not 40, and found no difference in risk among the 16% of MSM participants who had a bacterial STI during the study, I'm just hoping someone could explain why the particular criteria in Table 6B were chosen to support the distinction between a low but non-negligible and a negligible risk for HIV transmission. So just any evidence that you can remember, basically to explain why you chose, for example, 40, or why you're differentiating based on a bacterial STI, given some of the evidence suggesting that that may not actually be relevant in cases with a stable low viral load.
I think when we reviewed that, and unfortunately Patrick, who is leading that working group, isn't here to address that specifically, there's not only the partner study, which is an observational cohort study, there are other studies like HPC 052 that inform that conversation in a sense. So So taking a viral load of less than 40 versus 200, I think was one of the sort of group conversations that we had. In the partner study, if I remember correctly, a number of people were actually excluded from the analysis from that study because they'd used nPEP in other situations. So I think at least 3% of people in partners had been excluded. And the STI part, Darrell, I can't remember off the top of my head that component, but
I can't recall either. We'll have to. I apologize. Thank you for the question. We'll reconsult again. And Patrick, who was pivotal in constructing this recommendation, unfortunately couldn't be here with us today.
Hi. We'll stay in Table 6B. You list sex trade workers as a potential source group. But you don't list clients, so are you implying that if a condom breaks between a sex worker and a client, that the client will be eligible for nPEP but not the sex worker?
So that is the implication of the text as written, and the thinking had been that there isn't as great epidemiologic data on prevalence and incidence specifically in sex trade workers, but the thinking of the panel had been that that does predispose to a higher risk of HIV in the population. So that was the thinking. Do you have feedback on it?
Well, I would say that there's no studies on clients because it's very difficult to study clients of sex workers, and that the sex workers are the ones studies, but we're not acquiring and transmitting HIV on our own. We get it from clients. So I think that it's unfair to position it this way, and I think that if you're going to include sex workers, you have to also include the clients. They're the people that we have intercourse with.
I think I agree with you. I think maybe it's the wording of how we look at sex trade in that context, because you've had a high risk exposure, which would be with either unprotected or condom break in the setting of vaginal or anal intercourse, which is a high risk exposure. And the question really is what can we say about the population or population prevalence? And that's where we lack data for sure. But there may be ways, and we'll see what the rest of the panels, the rest of the audience says in terms of feedback as to ensure that if you were a sex trade worker where that happened, you would receive nPEP. That certainly is our practice in BC. If you presented for care, we would consider that a high-risk environment, and we would offer you nPEP.
Absolutely.
Hi there. First of all, thank you very much for this huge amount of work. A couple of questions. First of all, among serodiscordant couples, 8 and 9 refer to heterosexual serodiscordant couples. And you talk about significant risk and negligible risk. Just wondering if you put numbers to those, or we're thinking about putting numbers to those in terms of viral load in the infected partner. That's my first question.
So we can answer that quickly just by, I'm sorry, we should have been more clear about that by referring folks. We tried to use language throughout the document that is, again, not fixed. We can adjust the terminology that we're using, but the terms that do appear within the text so far refer back to Table 6B, which is what some of the questions that have been raised before refer back to.
Okay, I would then like to know, because I haven't had a chance to check it yet, to see if it's consistent with what we have in our Canadian consensus consensus document on transmission guidelines, the ones that we're using in criminalization cases. It'd be interesting to,
Yeah, no, thanks for that suggestion. I believe that it is consistent actually with it, but we can again compare the text. We've refined the text a number of times. The spirit of it, I think, is consistent with that, but we can make sure that the wording maps onto it.
That would be good.
That came up in conversation, and I think we asked that group to make sure that the wording was consistent.
Yeah.
And it is consistent with the Quebec guidelines. It is consistent with the same language. Yeah.
Great. Finally, I may be missing it, but do you say anything about serodiscordant gay couples?
Yeah, so for serodiscordant gay couples, we think that the language, we tried many times to word the recommendation number 7, which is about men who have sex with men in general, in such a way that men who have sex with men who are in a serodiscordant couple, where again there's a non-negligible risk of having transmissible infection in the pause partner, would be captured in that definition there.
Okay, yeah, thanks.
So at the back of the room, I see somebody waving their arm. If a microphone could go there. No? Okay, just kidding. It was a false alarm. There's a question here or a comment here in this part of the room.
Did you have any consideration, or will there be in the future any consideration for pediatric exposures?
Thank you. That was something that we decided right at the outset of this process that we would not take on in this document. We recognize that that's an important area and that pediatrics often actually unfairly gets excluded. That being said, the expertise that we had, we felt on our panel would not allow us to make appropriate recommendations in that context. So I agree with you that there's a need for that. Unfortunately, these documents are not intended to apply to pediatric populations.
Just going back to table 6B, can you tell me what evidence you have to indicate that sex trade workers in Canada have a high level of HIV transmission?
It's about their prevalence as opposed to transmission. So the initial part of that assessment is to assess HIV prevalence within survival sex. Well, the data is from survival sex trade. Certainly Kate Shannon in Vancouver has demonstrated a number of studies that the HIV prevalence in that population is high. So there is data on a Canadian setting that suggests that they would have a higher prevalence.
But you understand that applies to about 10 to 15% of sex trade workers, survival sex workers, not all sex workers. But this is identifying all sex trade workers as a high-risk group.
Yeah, thank you for that comment. I think we did have somewhere else in the text where we specifically tried to distinguish between survival sex trade work. Actually, it's in the first sentence of the background of this document, but you're right that that was somehow missing from the table, so we can make that adjustment. Thank you for the suggestion.
I have a question about recommendation number 10, where it says other harm reduction interventions have already been implemented. I'm just wondering if you thought about the many people who inject drugs that don't have access to needle exchanges and methadone, that sort of thing, particularly those in rural and remote parts of Canada.
So thank you for that comment. I think that you're absolutely right that there are lots of gaps in terms of the availability of appropriate harm reduction strategies for people who inject drugs. In fact, I think the panel completely agrees with the spirit of your question or your comment. In a way, we hope that that's not inconsistent with the wording that we've used here. We tried to emphasize by wording the recommendation number 10 in this way that we feel that there is a need for other harm reduction strategies, that we shouldn't simply throw PrEP into the mix just because someone is injecting drugs. There are a lot of other strategies that are out there that that we think there is more data for, and that health systems need to find ways to make those more available. And then when folks have not been able to access them, then yes, this is also on the list. If you feel that maybe we can revisit the wording, but if you have specific suggestions on how we can reword that particular recommendation to get that spirit across, I think that that's in line with what the panel was thinking when they tackled this topic.
And also the evidence that this recommendation is based is the Bangkok study, which showed some benefit in the injecting drug population, but only after a few years of the trial and when other harm reduction methods were implemented. So I think that's also part of where it comes from. So, but there is probably a better way to phrase it, to not to be exclude.
Mm-hmm.
In the background for table 6B on sex trade workers, does it acknowledge that there is a very large segment of the sex trade that does not engage in any activities that carry any risk of HIV transmission? Sex trade encompasses people who don't actually come into physical contact with their clients and therefore have no increased risk.
Right. I think that would then be based on the exposure type that they had when you do that assessment. So if you'd had a lower risk exposure, then you wouldn't be considered no matter what the source population had been.
I think I might also just mention that so it's very helpful to have this session, because that's the third question now we've had about the terminology that we've used around sex trade work, and perhaps we have not adequately consulted on how we should be using, we should be expressing this. So again, this is what this whole process is about. This is a draft document, and we would invite consultation broadly. So if there's individuals and organizations that would like to weigh in on that from specifically the sex trade work perspective, that would be valued.
I think we can certainly improve our introductory populations at risk to define some of the nuances that we've talked about here, because I agree from the comments that we've had is that we've in our minds been very specifically looking at the data which has been driven by survival sex trade, and I don't know if that's come as clearly through as we would like. And I think now with the third question, we definitely perhaps have to have a more clear paragraph about sex trade as an HIV risk in the country.
Thank you. Obviously, an immense amount of work went into this. Was any consideration given to the fit between the Health Canada indication and the data that gave rise to that indication and your recommendations, and how access may be problematic because you may be suggesting effectively off-label use? So if and when Truvada is covered under public formularies, and we've already seen instances of private insurance companies restricting access based on preventative or off-label, was any consideration given to that and strategies around access? Because it seems like that's going to be a big issue that healthcare providers are going to have to be involved in.
Yeah, thanks for the question. I think I can answer the most direct way to answer the question is to say no. We did not explicitly look at the label, the Health Canada indication. This process began in the late summer of 2015. As you know, Health Canada approval only happened in late February of this year. Our mission, as we interpreted it, was really to look at the scientific evidence out there and to draft recommendations based on that evidence, as well as the evidence that the panel was aware of. So I think to the extent that, I think what you're also alluding to, Glenn, is the need for what role can a document like this play in kind of advocacy, and how can we be, well, what's the dynamic between what we say in this document and what's on label in Canada? I think we have intentionally divorced ourselves from that, and how individual actors choose to reconcile that any differences is something that they can decide on independently.
Darrell, for your nPEP, the rationale for raltegravir as opposed to other integrase inhibitors, under what circumstance do you think people would choose boosted darunavir over an integrase inhibitor? And lastly of all, the lack of monitoring. We occasionally see kind of acute renal failure with tenofovir, and to not do a creatinine over a month, is that appropriate?
Well, we can discuss it as a group. So in terms of the integrase component, we based it on the strength of the evidence, which was raltegravir as the most well-studied integrase in the context of nPEP. We have in the table, I don't know if you have the table, but in alternatives, we recognize the role, perhaps on a clinical basis, of using dolutegravir, or even alvategravir. So it should be in one of the tables that you have. But the evidence at the moment, we know there are ongoing studies and trials, but the evidence at the moment supports raltegravir as a predominant integrase. In terms of choosing a PI over an integrase or vice versa, I think the pros and cons, which we heard about the regimens, we do have a number of recommendations where we recommend a protease inhibitor primarily for situations where we suspect either acute HIV, so you're putting somebody on nPEP, but they may have acute HIV that you're working them up for there. Without a genotype being available, you'd want to keep them on a PI until that information came back if you're going to treat them for HIV. And also in situations if they've had a risk exposure from a known HIV positive source that again could have HIV drug resistance. I don't know if you want to comment on that a bit more.
Yeah, I think those are the primary reasons that we had suggested those two in those circumstances of when you would choose one over the other in those situations. And then with regards to the monitoring, certainly I think when, although there were some reports of some myalgias and a CK elevation in the raltegravir groups, most of those individuals actually went on to actually resolve without actually any change in treatment. So certainly we do recommend doing some monitoring if symptoms arise. And then with respect to any renal monitoring, there was no signal that we probably need to do something in between unless anyone had any symptoms. So the trials didn't show that anybody had Fanconi's during the 28 days receipt of PEP.
So surprised that there's so little additional discussion. We have a full 15 minutes that we're free to continue the conversation. So please invite more scrutiny, more commentary. Anything else anyone wants to raise with respect to the document? Yeah, in the front. I think a microphone's on its way.
So I was a little curious about number 27. You didn't elaborate much on this about assessment for consensual versus non-consensual exposure. I get the need to screen for sexual assault, but I'm wondering if any consideration was given to the criminalization of the non-disclosure of HIV status and how that would play out in this screening for sexual assault, since those laws are used to criminalize the non-disclosure of HIV. I don't know if you're following what I'm saying. You don't look like you are.
So I think, if I've understood the question, did we explicitly tackle the issue of criminalization? So the answer to that is no, we did not. We were really looking at the scientific evidence that we could find in terms of how to deliver PrEP. You're right that in this context that we are unfortunately in right now with criminalization in Canada, that was an issue that the panel raised. We would perhaps like to, once we have this set of documents in this consultative phase, specifically ask experts in the field and other organizations in Canada to reflect on this documents in the context of criminalization, but we didn't explicitly tackle it. Is there a specific concern or suggestion did you have in that regard? Like what are your thoughts on the topic? Why do you bring it up, the question?
Well, I just think that this recommendation is very vague, and it needs to be really clarified that if clinicians are going to be asked to screen for sexual assault, that they need to be trained to screen for sexual assault, and that especially for expanding it to various healthcare workers, well, they can't just have a recommendation like this that's too vague for them to know what to do, and it could easily lead to some people deciding to get the police involved if they feel that it was a non-consensual exposure to HIV despite being a consensual sexual act.
Okay.
I think our thinking was more about not, at this point, we may not know about the source in terms of the HIV is more to clearly highlight that we recognize that some people have been in a situation where they did not consent to this exposure. And so we maybe need to have some wording how we improve that for sure. Because this wasn't so much about the criminalization of HIV, it's more to recognize that there are additional support services that would be needed for somebody that's had sexual assault, had a sexual assault, I should say.
Yes, absolutely. I see the intent, but it's more the phrasing and the
no,
elaboration.
I think that's important that we get some feedback specifically about wording that might tease that out a bit better. Because the intent was really to make sure that somebody hasn't had their sexual assault brushed away or ignored because we weren't recognizing it.
But I think that we have to be very cautious whenever we give medical doctors a mandate to screen for things that are not medical, to make sure that we give them the appropriate training guidelines so that they can do that job correctly.
Yeah. Thank you for the comment. In fact, as I recall, there was, as you can imagine, many of these recommendations it was a very iterative process. We've revised the wording over and over and over again. And in a previous iteration of this, I know that we had text in here that talked about the provider being prepared to deal with it, which is an allusion to what you're talking about. I think the training, the preparedness of the provider, that's not present in this current iteration, so we should work on how to address that appropriately. Thanks for the suggestion.
I think the original recommendation was a very lengthy one about the provider's experience and ability to actually make that assessment. And then I think it got cut down a little bit in terms of what it was, but we can go back and look at that.
Yeah. Is there a comment to the back of the room? Yeah.
I just wanted to circle back to the comment about people who inject drugs. I think that recommendation sticks out because it combines sort of what we, on a population level, yes, needle exchange and opiate substitution might be more effective than PrEP, but these are recommendations for individual providers who have an individual patient in front of them. And having needle exchange in the community still isn't a foolproof means of HIV prevention, nor is methadone, especially if you're not an opiate user. And so I think that having that in the recommendation doesn't help a provider at all who has a patient in front of them in that moment. And I think anything that can be used as grounds for refusal of unnecessary care to people who inject drugs should be avoided, given the barriers they already face.
Well, I think the point that has been well taken from the previous. I think we need to rephrase it so that it is not exclusive, that it doesn't open the door for refusing PrEP because a harm reduction program is not in place in the community. So I think your point is well taken, and it will be rephrased.
But I think it still has to be an evidence-based recommendation for the level of evidence in the setting of IDU.
Yeah, really the challenge I think that we faced in this particular section was the relative paucity of data on the use of PrEP in the injection drug using setting. There's a single trial in a very different setting with a different drug, tenofovir disoproxil fumarate on its own, not TDF, FTC, and various methodologic concerns about how that trial was conducted, et cetera. So that's what led to what you see on the page. But thank you for the comment again.
Yeah, and I think, Aidan, we're hearing your comments, and I'm looking to Joe. We're completely open to the wording around that, so we'll take a look at it as a working group.
Great. I think there's a question in the front here.
I just want to know if any recommendation was made for the price of the medication, because I see a lot of, I work in prevention, and I see a lot of people who should have access to PrEP and will not because they do like $30,000 a year, so they don't have access. They will have to pay like $83 in Quebec. They will have to pay $83 a month, but they don't have their $83 a month. So, but they could be in danger to have HIV. So, any recommendation was made for that?
Yeah, that's always the elephant in the room with respect to discussions around PrEP in most parts of Canada right now. I guess, again, the short answer to your question is no, it does not appear explicitly in the text at present. Again, the reasoning for that was really that the panel was interested in looking at the science behind what are you going to do and how are you going to do it from a bit more of a clinical perspective. Issues of cost and how the impact on access is a huge problem, and I think we recognize that. The panel did have discussions around how we can at least raise this issue in the text of the document and recognize that we weren't convinced that we had data in front of us to allow us to make firm recommendations around, firm recommendations to health systems really about exactly how to get this thing covered. But thank you for the comment. I'm not sure if others want to comment on how we can tackle that very important but challenging topic.
I'm not sure if we have solutions, but I think I do believe that CADETH, or the Canadian Drug Review Board, will be reviewing the use of Truvada for this PrEP indication, actually, I believe next month. So I'm hopeful, and at that time they certainly make recommendations whether they recommend to list with a price change. So hopefully this document maybe serve as an impetus as why it's needed and why universal access for those that need it should be encouraged. And so I'm kind of looking forward to them to solve the problem. But certainly I think hopefully this will add to the need.
And I think this is a community dialogue that we have to have with policymakers and payers, because I don't think there's any single person on the panel, and certainly probably most of you in the audience, that doesn't feel very strongly that PrEP should be made available and made available to the people that need it at a price or without price. It should support people being protected from HIV. From a clinical standpoint, I think I personally view these guidelines as you said, an impetus in that direction, which is this is advocacy to clearly lay out that we have expectations for how clinicians should be able to access PrEP, guide them in terms of how best to do it, but to have clinicians have that tool available, this goes up to policy and to payers, and I think this is our first step in terms of reviewing the evidence and having some nudge in the right direction, we hope.
Yeah. And that's not to say those conversations weren't happening. We had a lot of conversations about accessibility, and certainly we opted not to include them in the recommendations, thinking that that's another way to do that.
Yep, the side here.
Kelly McDonald. Hi, Darrell. I guess this is continuing on that vein. I'm just wondering if you think that these guidelines, when they're finally published, will have any effect in at least shaming those jurisdictions that don't have up-to-date policies in terms of PEP and PrEP. I know that my new jurisdiction here is still using, I hate to even say this, Combivir and Kaletra for post-exposure prophylaxis. And this is 3 years after most jurisdictions have changed over. I think that we really have to become much more, I think, activist as caregivers in terms of some of these issues for our patients, for whatever it's worth.
Thanks, Kelly, for the comment. I think completely that we hope that this set of guidelines can be a tool in that regard. And again, one of the motivations for, there's been a lot of calls for the need for a document like this in Canada. It's been absent for, well, until now. And many people who we told we were developing the guidelines were happy about it because it could be used in all kinds of ways. And again, one of the main goals of developing a guideline in general is to reduce inappropriate variation in practice, to update people on the most recent evidence. And so, yes, we can use it in that sort of way, absolutely.
Again, along the same vein, there are a number of us in the room, community side and physician side, working on the access issue. I think in our discussions, it's clear to a number of us anyway that there are 3 issues regarding access. One, and they are likely to be, questions asked by drug benefit formularies, whether they're public or, as we're about to see, private as well. What will the cost be? What will uptake look like? And what can you tell us about implementation? So obviously, I think the guidelines are a huge part of the work that and the information that we can provide that will illuminate implementation considerations, both in terms of when there would be uptake and in which populations. But I just want to say there are people here like me and Glenn Betteridge and others in the room. If anybody wants to come and talk to us some more about some of the access issues, we're happy to talk about them.
Fantastic, thanks. I think there was a hand, towards the corner there. Oh, no, sorry. But, go ahead.
I am said Glenn Betteridge from CTAC. CTAC, along with Katie and PositiveLight.com, have consulted widely in community on a Canadian consensus statement on the use of antiretroviral medications and HIV testing. Part of that document offers consensus statements around PrEP and nPEP. So it supplements the clinical consensus statement quite nicely in terms of advocating for broad access based on holistic models of care and social determinants of health. And we're launching that document here at CAHR. There's a little card in all of your packages, and there are copies of the consensus statement in English and French at the Katie table, and it's available online, hivconsensus.vih.ca.
Thanks, Glenn. I'm mindful of the time. I think we can take one last question or comment in the corner there.
Thank you. I just have a question regarding the certain Canadian Aboriginal populations outlined in the background, and I'm wondering, given the dynamic environment of Indigenous identity in this country, if there is going to be a certain recommendation that will consider the various jurisdictional issues that may affect Indigenous populations. So just a flag on the wording and question about what do you mean?
Do you want to comment?
I think our initial data was just sort of from the PHEC initial priority populations, and I think we're definitely open for our preamble and introductory paragraphs, as we've already talked about, in terms of more clearly refining our wording regarding sex trade to have the similar conversation about Indigenous populations. And there definitely is an overlap between what the federal responsibility would be and provincial. And any wording you have or suggestions you have in that regard, we certainly would be very appreciative of.
Yeah, I guess the spirit behind the choice of the addition of the word certain populations was an effort to acknowledge that there is tremendous heterogeneity in Aboriginal populations across the country. So again, for specific suggestions on how we should appropriately refine the language, it would be greatly appreciated. I think with that, we're at 5:15, so I want to thank all of you so much for your active participation. We had a lot of really useful feedback. Okay.
I guess we're done.
We're done. Thanks.
Ladies and gentlemen, the opening ceremonies for CAHR 2016 are about to begin. Please take your seats as the ceremonies will commence in 3 minutes. Thank you.